The virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the virtual Curbside. This is your host, Paul Wirkus. This is the week that we always look forward to, where we can address some questions that have come in about the things we've talked about. So we're talking about measles this month. We should probably make clear that all of this conversation is happening in June of 2025 because things evolve as we go along. We're very fortunate to have Andy Pavia and T.W. Jones back with us this evening. Real world problem. Mary Fortini was unable to join us tonight because she's practicing infectious disease this evening in the hospital as we speak. Welcome back, Andy and TW.
Thanks for having us.
Thank you so much.
Any disclosures you want to talk about?
Well, nothing has changed for me. I received royalties as an editor of the Sanford Guide for Antimicrobial Therapy, and I did some consulting for Haleon a few months back.
And I have no disclosures, financial or otherwise.
We're looking for something for you, though. Let's dive right back into these topics. The first question is sort of an extension of what we were talking about earlier. Would you mind talking a bit about post-exposure prophylaxis for measles? Who's eligible, who needs it? And if someone has been exposed, what should I do as their doctor?
Yeah, so what I'd recommend is anybody listening to this podcast where this question comes up is the American Academy of Pediatrics has the Red Book to refer to. Again, I have no disclosures like I mentioned. In fact, I pay the American Academy of Pediatrics, so that's like a negative disclosure, right? But I think this is a fantastic guide when you have a patient who may have been exposed to measles. It really breaks it down, gets very granular. What age are they? Do they have any prior immunity? Are they immunocompromised? Are they pregnant? Are they immunocompetent? And it gives you just a really nice, easy to read table. But what it boils down to, just for this podcast, is the MMR vaccine can give you protection or at least favorably modify disease for you if you're an exposed but non-immune person. But you have to get it within 72 hours of exposure. If it's less than 72 hours and the person is non-immune, otherwise eligible for the MMR vaccination, that's your post-exposure prophylaxis of choice. If the person's not eligible for that MMR vaccine, so let's say it's an infant less than 6 months, or it's a pregnant person, or an immunocompromised person, somebody on high-dose steroids, for example, then they're recommended to instead receive immune globulin. So that could be intramuscular or intravenous. Now remember, immune globulin is a product created from the antibodies of thousands of donors, of blood and plasma donors, and hopefully provides a cross-section of the serologic status of the community. And so hopefully many of those people are immune to measles. So hopefully those immune globulins are going to give measles protection. If you are a person who gets immune globulin, IM or IV, then they do have to undergo home quarantine because they could develop a modified or contagious measles infection. Lastly, kids who receive immune globulin, they still need to get vaccinated. So that's just passive immunity. Those antibodies are going to wash out of the person. So they need to get vaccinated, and it needs to be 6 months after intramuscular immune globulin administration or 8 months after IV immune globulin administration.
For the same reasons we talked about before for why we don't do the MMR until 12 months.
Yep, exactly.
I was going to add two things that people should keep in mind. The dose of immunoglobulin IM is a half cc per kilo. So the max you can give anyone reasonably is about 10 cc's. So that means that really the IM is only suitable for infants. We don't use it for adults. For the pregnant women and the immunocompromised older kids and adults, it's IVIG, and so that needs to be arranged for.
10 cc's would be a whole lot, IM.
Yep.
Yeah,
You would feel that one.
Yeah. I guess if you've got great big muscles, that would be a challenge to take on.
The way you would do it for an adult, which is not advocated, is you break it up into 4 doses, 2 in the buttocks, 2 in the vastus lateralis, and then they're not going to walk for a couple of days.
So again, we're aiming for IV.
Yeah.
Perfect. Next question. On a related note, how long does it take for the measles vaccine to provide protection? You've sort of addressed that. And is it a gradual curve or a steep curve? Does it provide a lot of initial and then level off, or is it sort of a slow gradual increase?
So what generally gets quoted is that 2 to 3 weeks is how long it takes to provide protection. It's hard to say in any specific individual exactly at what time point you can say they are fully protected. So the 2 to 3 weeks is a little bit of hedging just based off of what is the bell curve of humans out there who receive the vaccine. But because of that, they say that when you're traveling to a measles endemic region, and if you are a person who's non-immune and trying to get vaccinated up before going there, it's recommended to get fully immunized at least 2 weeks before departure so that hopefully you're getting that protection before you leave and wind up in a measles endemic region.
The fun part about B cell response is something called affinity maturation. So the amount of antibody peaks at about 4 weeks and it may go upward slightly. But one of the really interesting things that happens with most humoral immunity is the antibody genes are rearranged over the next out to 6 months. And so they become more effective and more targeted through this process called affinity maturation that has to do with gene rearrangement. So your maximal immunity is probably at about 6 months, but this vaccine's so good that you really have pretty good protection 2 to 4 weeks out.
That's fascinating. What's a little bit frustrating in some ways is that this has been a very effective and safe vaccine, and yet we see a decrease in its use.
Yeah, it's been a target of the anti-vaccination movement ever since the wholesale diphtheria, pertussis, tetanus was taken off the market. And in spite of study after study showing that it's actually much safer than many of the other vaccines we give routinely, it continues to be a target of misinformation.
Question number 3 is sort of a clarification or maybe just amplification of something you talked about on the podcast. How long does immunity last from a measles shot? And is there a rationale for getting a third dose at some point in one's life?
Generally speaking, most people have lifelong immunity from getting the full series, the two vaccines. There is some data that suggests that maybe 5% have some waning immunity after several years. You wouldn't know that unless you necessarily went and did some serologic testing. But for now, there aren't any recommendations for receiving a third dose for measles protection. But if it were done, it would be unlikely to be harmful. Of course, I don't know what that would mean in terms of issues for payers, of course.
I think one of the challenges for providers is that a lot of us have come through a time when maybe we weren't as cautious as we should have been in recording vaccines. And so it's difficult to verify what we've had. So, what you're saying is if I were to get a third one inadvertently, not likely to be a problem. And if I can only verify that I've had one, I should get a second one.
Absolutely.
Yeah, I would totally agree with that.
And remember, because it's a live vaccine, the side effects are actually worse when you get the first dose, such as they are the fever, the potential arthralgias, and rash. So if you get a third dose inadvertently and you've got a pretty good immune response to it, you're not going to get that much viral replication, and you probably won't have any side effects other than possibly a sore arm, and even that should be attenuated.
Why are the side effects worse with the first dose?
Well, with live vaccines, they're replicating. And if you have no immunity, they replicate as they're planned to. So you get about 7 days of active replication, which tails off to about 14. When you get dose two, your immune system kicks in and controls viral replication. At the same time, it boosts the memory function and lays down more memory B and T cells. So you have less virus lasting. It's one of the reasons why adults don't respond to FluMist, the nasal flu vaccine, because we have pretty high levels of immunity to flu. And so the virus doesn't reproduce well in our nose. But when you give it to your 5-year-old, they get a nice response.
Also, just to add to the point of getting an extra dose or more extra doses of the MMR vaccine, remember when we have children who are adopted from overseas or who come from overseas as refugees, and if they have anything like a dubious vaccination record or an unclear vaccination record, generally the practice is to just err on the side of immunizing them up to full immunization status in a well-documented vaccination record. And that certainly means some of those kids are getting extra doses of MMR vaccines, and that is fine. They do great with it.
No concerning side effects there.
Correct.
It has always seemed to me that if somebody's going to get a rash with a measles vaccine, it's with the first dose, and it's usually about a week and a half after the dose. Is that accurate?
Yes.
Yep, that's right. Remember, rubella although a much milder virus, also can cause a rash. So we don't know for certain which virus caused your rash if you get a rash between 7 and 10 days out.
Very interesting. By the way, Andy, I should point out after your comment in the first episode, I had a colleague say, well, I saw a child in clinic. They had a rash. They had a little bit of a pink eye, and I was wondering if they might have measles, but they didn't look very sick. And so, way to educate us.
So where I would be cautious is in the child who's got one dose of vaccine, because there you have less complete protection, but you may have modified disease. So that may be the group of kids where you're not looking for them to look quite so crappy, but they still should have cough, significant fever, and probably some conjunctivitis. But that distinctive, pretty sick look that kids with measles who are unvaccinated have might be absent.
Very good point. This is a child who had very mild looking illness, but we're all on alert right now.
Yeah. And of course, we've got parvovirus in the community right now, which isn't
Yeah,
helping.
that doesn't help. Next question. On a side note, are the mumps and rubella vaccines similarly protective to the measles vaccine? Do they need to be thought about separately in terms of boosting and that sort of stuff?
The rubella vaccine provides pretty durable immunity. CDC says that in general, it's lifelong. There's not enough circulating rubella in the US for us to really have much good data about fading of immunity. And of course, if you do any obstetrical medicine, occasionally you'll see somebody who has documented vaccination but has an undetectable rubella titer.
Right.
But it's pretty long lasting. Mumps, though, is quite different. Mumps immunity does fade in a substantial number of people. We've had outbreaks of mumps. We had quite a surge in 2017 through 2018 and 19. There were outbreaks in summer camps. There were outbreaks in high schools. They were relatively small, but they were occurring in vaccinated people. And then there was one of my favorite outbreaks, which some colleagues of mine got to investigate, which was a big outbreak in the Chicago Board of Trade. And so a lot of traders became ill with mumps. And one of the things to remember about mumps is that orchitis is one of the manifestations, and not just parotitis. And the older you are, the more likely to have orchitis instead of parotitis. So you can imagine all of these big deal bond traders running around with orchitis.
Sounds awful. Running around a little bow-legged, I'm guessing. Sounds terrible. Next question. This has nothing to do with anything we've talked about. I know that this podcast is meant to be all about measles, but would you care to comment on what we ought to be doing with COVID vaccine? Again, it's June 2025. What we ought to be doing with COVID vaccine for kids this upcoming season? If yes, should we be doing it? When and how? And are there new things we ought to know or to be saying about the vaccines in children, adolescents, and young adults?
Yeah, so this is going to be a very difficult issue going forward because of the unilateral actions that RFK Jr. has taken, along with statements that have come from Marty Makary. There hasn't been any change in the science. So what the science tells us is that kids who have never had COVID vaccine or COVID infection, which is largely infants, are at risk for very severe disease. The best way to protect infants is, in fact, for the moms to get immunized because, of course, COVID during pregnancy can be quite serious or even fatal. And so that change in the recommendations that came from, I'm going to be brutal and say RFK's fever dreams, is not backed by any science. ACOG, AAP, all the professional groups have come out to say we should continue vaccinating pregnant women to give infants some protection. There have been a substantial number of serious cases of COVID in the last 2 years among kids, but of course the numbers are relatively small. There were about another 100 deaths, about half of which were among kids who were previously healthy. But the overall impact on kids who've been vaccinated before and who have had COVID 1, 2, or 3 times is going to be fairly modest. So I think the vaccine still should be available to those kids. Whether or not everyone should get it and whether they should get it every year, I think is a little bit more debatable. There was going to be a very thoughtful evidence analysis at ACIP. Of course, that's not going to happen because the ACIP members were all fired. And that would have been a very important discussion to think particularly about kids in that sort of 5 to 18-year-old age. What do we tell parents about whether or not they should get re-immunized? So my take is that Any child with no immunity to COVID should get vaccinated. That, I think, is a strong recommendation. Any child with multiple bouts of COVID and several doses of vaccine probably does not have a great deal of benefit from getting another booster this year. They may, at some point in the future, need more boosters as immunity fades, but I think their protection is probably pretty good. And that becomes, I think, a parent's choice. So CDC still recommends vaccination for children, even though HHS leadership has said otherwise. We'll see how that plays out. Is that helpful at all?
I think it is. So the instructions that came with the order for vaccines for children doses this year say that you need to document an increased risk to give the COVID vaccine for children. What sorts of things do you think are going to be the things that merit immunization that are going to satisfy the requirement?
I'm glad you brought that up, Paul, because it's really pretty important. So, to qualify for immunization, the list is very long, and it includes asthma of any degree of severity, any sort of heart disease, any form of diabetes, any neurologic disease, and those are the big ones, any form of immunosuppression. But we spent a lot of time looking at the data on who really got severe disease among kids, and so we can sort of refine that a little bit. Children with moderate to severe asthma who are on daily controller regimens have an increased risk of severe outcomes. But kids who need an inhaler once a year when they get a cold, that's probably not a serious risk. Diabetes, it appeared to be a greater risk for type 2 than type 1 in the data that we saw. But I think any child with diabetes, I would probably recommend immunization for. And with immunocompromised, the challenge is the people who need it most will respond most poorly to vaccine. But any child who's on a significant dose of prednisone, say more than a milligram per kilo, any child who is on a biologic other than rituximab, which will completely block their ability to respond to the vaccine, any child who is within a year or two of finishing their cancer therapy, these are the kids I would really vaccinate.
One other question while I have you, because we've now seen a whole lot of doses of the COVID vaccine used. Would you like to comment on your feelings about an mRNA derived vaccine at this point? Any wisdom that we ought to have from that after 5 years into it?
Well, if we want to be really brutal about the pluses and minuses of mRNA vaccine, the list I'm going to give you is totally different than what you're going to get from an anti-mRNA person. So their benefits are they're really easy to make quickly and to match to circulating viruses. They generate a very good initial immune response. They're really very safe in terms of long-term side effects, with a couple of exceptions that we need to be aware of. And, one is those systemic symptoms that occur in about 20%, the aches, fever, sore arm, and lymphadenopathy. That can be bothersome. And then there is the issue of myocarditis, which is pretty much limited to young males between puberty and about 28. The numbers have fallen dramatically since the Omicron days, but cases have still occurred. So it's a rare side effect. Its peak estimate for the highest age group is somewhere, depending on who you read, between 18 and about 45 per million. So not very common, but not super rare in that age group. So those are the pluses, and I consider the side effect profile to be a plus. The downside, as we've all seen, is that between viral drift and probably just the biology of the mRNA vaccines, they don't provide very long-lasting immunity. And so that's clearly an issue. Unfortunately, the protein-based vaccine, the Novavax vaccine, doesn't seem to provide a lot longer duration of protection, and even natural infection has waning immunity over time. So it's probably the nature of the SARS-CoV virus that it doesn't generate a measles-like long-lasting protective immunity.
Excellent touch back to the topic. Can I just ask one more question about that? What do we know about the long-term data about the young men who have had myocarditis following immunization?
Well, our colleague, who unfortunately has left Primary Children's, a very well-known cardiologist researcher on this, published one of the best studies on this. At the risk of misquoting it, about 90% of the people were at completely normal cardiac and physiologic functioning at 3 months. And of the 10% who still were not quite back to baseline, most had returned to baseline at 6 months. So the vast majority have very mild and reversible myocarditis, which is different than some of what we saw with COVID, and certainly the kind of severe heart damage that we saw with MIS-C. And we saw quite a number of adolescents with myocarditis at primary during the early days of vaccinating that age group. And most of them were completely recovered by the time they went home.
Good news. Anything else you want to share about either that or the measles?
Well, we're recording. I like to timestamp everything about measles because I feel like the bullets are whizzing by. So we are recording this on June 16th at 7 o'clock in the evening. And the only case of measles we've had was one man in Southwest Utah who was visiting from out of state, who apparently stayed with his family. We're not aware of a second wave of cases from that family yet. So Utah is still measles free as far as we know, although I have my concerns. Idaho has had only one case, and that was also in a traveler. But unfortunately, Arizona, New Mexico, Colorado, Montana are being hit fairly significantly.
And we don't have a wall.
Yeah, I don't know, Paul, are you going to build it?
No, we like all of our neighbors. It just turns out that does increase the risk, but by the end of the summer, it won't be the same story.
Yeah. And of course, since Utah is such an important tourist destination, we can anticipate that we'll have travelers with measles coming through. So I'm concerned that we're not done with measles yet.
Sure. But I hope the message that I think both of you have been very clear about is that we have an excellent way to protect ourselves and our children against measles, and it behooves us to not take it for granted that the measles vaccine is an amazing technology.
And I would just add, honestly, in the history of public health, we have so many setbacks against so many preventable diseases that were eventually overcome. You know, the story of smallpox is not a story of just success after success. There were numerous outbreaks even after the introduction of smallpox vaccination to many different regions throughout the world. And I think the lesson that I have here for measles is that this is a winnable fight. And I think it is winnable. I think we are going to win it. I think there are some setbacks here, and I think it just means that we have to renew our diligence in vaccinating our communities and in helping people understand the importance of vaccination. But there's always hope. There's no reason to feel upset or to despair about outbreaks that have come back to this country, because in the end, I really do think this is going to be something that we're going to overcome in the long term.
Excellent. Well, TW, Andy, I always feel a lot smarter after talking to you guys. It doesn't last very long, but I feel a lot smarter, at least temporarily. Thanks so much for joining us this month. And please give our best to Mary. And I hope to talk to you again sometime.
Thank you so much.
Thanks, Paul. It's been great to talk to you and to everyone that we're virtually talking to.
Excellent. All right. And to our listeners, please tell your friends and neighbors, and we can all make a difference out there. We'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design, thanks to Paul Wirkus, who also composed the theme music. See you next time.